Hello.
Hello, how's it going?
Good. Welcome back, everyone, to Snack Chats with TLB. I'm Sarah.
And I'm Anna.
And Anna, what are we talking about today?
Today we are going to be talking a little bit about what is an eating disorder. So, we're going to talk a little bit about diagnoses, what we use them for, the limitations of diagnostic criteria, and just getting a little bit into distinguishing, yeah, what the different types of eating disorders can look like, both from like a diagnostic perspective and from a behavioral perspective.
Yeah, for sure. Yeah, and just like small disclaimer, as dietitians, we don't actually do diagnosing. So we're not allowed to like give somebody a diagnosis. We are typically getting this information if we're needing it for insurance, which we'll talk a little bit about. But essentially, we are obtaining the diagnosis from another medical provider, a therapist, a
Mhm.
psychiatrist, a doctor. And so I'm going to have notes pulled up today because truly, like, I don't look at the DSM-5, which is the way eating disorders are diagnosed. I don't look at that when I'm working with a client because I can't diagnose them anyway. So,
Yeah, exactly. It would be lost on me.
so yeah, but I just wanted to include that. And again, yeah, we have lots to cover today as far as just what the different eating disorder diagnoses are, but then also limitations with diagnoses and how we approach this, having this information with our clients.
Yeah, totally. Yeah, speaking of the diagnoses, and kind of what we use them for, because yeah, if we can't diagnose, what are we asking for like the diagnoses for? We use them a lot for like insurance purposes. So a lot of times it can help get better coverage for people. That's not to say that someone needs an eating disorder diagnosis to work with a dietitian, but that's kind of what we use them for. And even though we do use them, they're not the end all be all for us as it relates to you know, classifying severity or like the type of care that we provide. So we'll talk about that a little bit towards the end as well, but wanted to give that little disclaimer.
Yes, so important. And we
Yeah.
actually have another video on our YouTube channel about disordered eating. And so if somebody doesn't specifically meet the criteria for a diagnosed eating disorder, that does not mean that there isn't disordered eating behavior showing up. And so if you're wanting more information about that, we do have a video about that on our YouTube page as well.
Yes, sweet. So should we dive in?
Let's dive in. Let's do it. All right, where are we starting? Anorexia nervosa.
Anorexia nervosa. So do you want to tell them a little bit about it or do you want me to?
Anna, you take it away. You take the
I'll
first one.
take it away. Okay, so basically, and you'll see that I'm also looking at some notes, but basically with anorexia nervosa, what we're usually thinking about is restriction of energy intake. So, a lot of times that can be through limiting times that you're eating, limiting the amount of food that you're eating at your meal times, right? But like overall, what we're kind of seeing is like an overall like energy of restriction. Um, I have some qualms with this. So here's like my first caveat about this, but a lot of times anorexia gets kind of divided into like classic anorexia and atypical anorexia. And the only thing separating those two things is weight from a diagnostic perspective. I find that to be a little bit useless because to me, I'm like, a behavior is a behavior, and I'm going to treat it the same whether or not a person is at a low body weight, like a quote unquote low body weight, or a quote unquote like normal or like whatever it might be, like BMI based, right? So you'll hear a lot of that language used when it comes to anorexia, but at TLB in general, I think we all agree that like we kind of tend to look more at like what are the behaviors going on. We might also expect to see, like in most other eating disorders, not all of them, we might expect to see a disturbance in like body image for people. So that can look like body dysmorphia, right? Or it might just look like um, intense like dissatisfaction with body, whatever it might be. But usually with anorexia, there is a pretty strong like body image or like concern with weight component, right? So that's kind of what I think about when I think about anorexia, but I'm curious if you would add anything to it.
Yeah, no, not necessarily. I mean, I just love what you said about, a behavior is a behavior, right? An
Mhm.
individual's weight is not dictating how we are approaching those conversations or providing support to a client. Um,
Mhm.
yeah, I think there's a lot of nuance with that, but whether somebody comes in with, yeah, like you said, like this like classic anorexia nervosa or not, we're still providing the same type of care and treating the behavior the
Mhm.
same.
Yeah, totally. So yeah, if we're good on that one, do we want to talk a little bit about bulimia nervosa next?
Yes, absolutely. Okay, so here I am looking at my notes here, right? So yeah, I think there's a lot of nuance to this here. So I would say it's the criteria is essentially like either vomiting, using laxatives, fasting, like trying to, I don't even know how to word it, but like whether it's like get rid of food or severely restrict food, because it also like fasting and excessive exercise can
Mhm.
be. So I think they're compensatory behaviors, right? Like typically
Mhm.
following eating, it's a compensatory behavior to in response to that. A lot
Yeah.
of times I think too, it would be classified as eating a very large amount in um, like a distinct period of time, feeling a loss of control with eating, and then again, following that up with the compensatory behavior, whether that's again,
Mhm.
vomiting, laxatives, exercise, fasting, anything
Mhm.
like that. So the diagnostic criteria is that this occurs at least one time a week for 3 months.
Yeah.
Again, we're not necessarily using this specific time frame. Like if somebody's coming in engaging in any of these behaviors, we're treating it as such, whether that's been going on for 2 weeks or 3 months or a year, or whether it's one time
Mhm.
a week, 3 times a week, 5 times a week, right? Like they don't an individual doesn't have to meet a specific criteria in order for us to support that client and have these important conversations and analyze the severity of the behaviors and like the body's response to the behaviors.
Yeah. Yeah, I think what I would add to it, just hearing you kind of talk through, yeah, like maybe like the discrete period of eating being more of like what we might call like binge type behaviors, right? Or like binge
Yeah.
behaviors followed by the purge, which I think a lot of times people think of like purging as like vomiting or something like that. But a lot of times, like purging can look like purging through exercise, right? Or purging through, like you said, like extended periods of like restriction. Um, and I think it's interesting. I think Tina was one time saying, like, the way that she classifies it in her head is like, especially like with individuals when they can feel a little bit confused of like, I don't get it, like I'm eating. And it's like totally like you are eating, you're having these maybe like discrete, like binge type episodes or like whatever it might look like, but you're not really letting your body use the food for itself, right? Like it's either being funneled into like purging through vomiting, purging through laxative. So you're not really letting your body like actually either like digest the food or if it's like purging through exercise, your body's having to like use some of that fuel to just like keep you okay during the exercise. And it's not really getting to use that for all of these like basal metabolic needs that it has. So it's like, I think it can be confusing for people sometimes when they're like, I'm eating, like, don't worry. And it's like, totally, there's also all of this other stuff going on that's preventing your body from actually using the food that you're eating for what it needs it for, which is like to keep you alive, you know?
Yeah, absolutely.
Yeah.
No, I think that's such an important distinction.
Yeah. So, yeah, I think that's the only thing I would add to the bulimia conversation.
Yeah, absolutely.
Oh, and that there, sorry, I was like, that's all I got. And then I was like, nope, I got one. But that there is typically also a body image component to this one, right? So, like, all of this is like not black and white of like if you don't have a body image component then like that's not what it qualifies as, but like often there is like a either like body image component or like an almost like sensory experience of body, right, that like is being taken into account, is the only other thing I would add.
Yeah.
Yeah.
Yeah, definitely. Yeah. And I love that point too, because I think it's like whether it's body image as far as what how the body appears, right? And like wanting a change, or it's almost like this physiological or like discomfort of the body. And for
Mm,
whatever reason, the purging again, like
Mhm.
whatever that, however that is happening, is providing something, right? Like some sort of
Yeah.
like potentially a relief or a comfort, even though the behavior might be definitely harmful. It's yeah, there might be something that does feel really like relieving about it. I think that's how a
Yeah.
lot of clients can talk about it sometimes. And so, but that would definitely fall under that like
Yeah.
body image or body just like sensation
Yeah.
aspect of it.
Totally. And then actually one more thing I'll add, then maybe we don't want to get into like the super nitty-gritty, but a lot of times, you know, like we said, we're not diagnosing, we're like treating behaviors in people, right? And it's interesting because even though like you know, the problem or like the core issue with both like bulimia nervosa and maybe like anorexia nervosa is like, oh man, like your body might not have enough like food to work with, right? Or like energy to work with. It's interesting that a lot of times like we need different labs depending on like what the behaviors are, right? So for someone with like bulimia, we might be looking at different labs because like different labs might be effective than for someone with like anorexia. And I feel like there was something else I was going to say about, oh, and that especially if there's like purging through vomiting going on for people, like, yeah, we need to look at electrolytes, right? Like, we need to, if someone is like taking certain medications, like, for example, Wellbutrin, you can be higher likelihood of like getting a seizure if you're also like vomiting while taking that medication, right? So it's like really important for us to know what behaviors are present so that we can like truly treat the potential like not like downwind effects of like the behaviors.
Yeah. Yeah,
Yeah.
and I feel like that's what too, what's so important about having a full medical team. It's like we're not prescribing medications. And so we're not like there may be instances where it's like, I didn't realize like this medication could do this. And so having a medical doctor or having a psychiatrist that's navigating that, and then
Totally.
we're able to collaborate with them and share this is what's going on nutritionally, and these are my concerns. Like just being able to work as a team is so helpful. And so, clients experiencing anything like this, like having a full team in place or like putting a full team in place is
Yeah.
so beneficial.
Yeah, totally. So I think
So
I'm actually done now talking about bulimia.
well, let's get into the next one. So our next eating disorder is binge eating disorder. So Anna, do you want
Mhm.
to talk a little bit about that?
Yeah, so binge eating disorder, it's already funny because I'm thinking of like 1 million caveats, but as you can imagine, there's going to be similar to with like bulimia, where there's like these like binges that a person is experiencing in. We would expect to see that in binge eating disorder as well. And my understanding is that like, you know, the criteria for the binges is the same between like bulimia and like what defines a binge essentially is the same for like bulimia versus like binge eating. But with binge eating, there's typically not either compensatory behaviors or precipitating behaviors. So what I mean by that is that like a lot of times, I don't know about you, but like I'll have clients who are like, I have binge eating disorder. And then we look at their overall intake throughout the day. And I'm like, it makes so much sense that you think that you have binge eating because like that's like the biggest distress or the biggest stressor that you're experiencing. You're also not eating enough early in the day, which can sometimes be from compensation, can sometimes be from like fear of eating, whatever it might be. That it's like that a lot of times is tricky to classify as like true binge eating disorder because what we would want to see is like not these like precipitating restrictive things or these compensatory kind of like downstream effects that a person might experience. So yeah, that's usually like binge eating disorder to me is like kind of how I distinguish it from bulimia and from anorexia.
Yeah, yeah, absolutely. Yeah, and I think the criteria, in my notes, this is occurring over more than once a week for again, like this 3 month period. Same thing goes for the other diagnoses. Like if an individual is coming in and this is happening, once a week and it's only been a couple weeks or a month or whatever, it's like the diagnosis itself isn't what is dictating how we're approaching these conversations and the support that we're providing for clients. And like somebody coming in without meeting these criteria is still, excuse me, very much deserving of care and deserving to like take up space in our client caseload.
Yeah, I completely agree with you. And And of course, I'm kind of losing my train of thought on that. Hang on, it'll come back to me. But
Yeah.
just that, like, um, the DSM criteria is intended to kind of create these like clusters, right? So that we kind of understand, like, okay, what distinguishes, like I said, maybe like sometimes you're like, man, for these behaviors, we need certain lab values versus for these behaviors, we want to look more at these other lab values, whatever that might be. But it's like, ultimately, it's kind of this like arbitrary cluster of criteria that we've created to kind of get our bearings around like the differences between, it's essentially like the differentials between different diagnoses, but it's not like, again, like we said, like it's not the end all be all of like, and this is true binge eating disorder, or this is like sometimes you might have someone who's like, you know, meeting more so like the criteria of like anorexia nervosa, and then they're like they engage in like a binge, and it's like, okay, like it doesn't really matter what diagnostic criteria they fall under, they're going to receive the care that they need either way from us, you know?
Right. Absolutely. Well,
So.
and I'm curious if you have thoughts around this, like with binge eating disorder. I think there can be a lot of confusion around what's a true binge, what's quote unquote overeating. Do you have thoughts
Mhm.
on kind of determining the differences there? Because to your point earlier, where some clients might feel like, no, I binge eat. And then as we dig a little bit deeper, sometimes it's like,
Yeah.
I, I wouldn't classify that as a binge, And so I feel like there is a lot of nuance there. And I'm just
Yeah.
curious if you have thoughts on those differences.
It's tricky because, for example, I don't want to use numbers, so I'm gonna use a roundabout way of saying this, but it's like there are times when someone is eating what is potentially more than what their body would prefer to have in one sitting,
Hmm.
right? Which might be equivalent to like essentially what their body would have preferred to have spread out over 3 meals and a few snacks throughout the day. And so it's like that can qualify as like a quote unquote like true binge, right? Or like a diagnostically like relevant like true binge, because it is like, okay, you're consuming a pretty significant amount of food in a short period of time, when like in reality it's like, well, this is just the amount of food your body would have preferred to consume spread out throughout like the entire day, right? And so I don't get like, I will challenge people sometimes if they're telling me that like something that I think is a really appropriate meal for their bodies is just a binge, because they might have a little bit of like a skewed perspective on like what a meal is quote unquote like supposed to look like. So I'll do a little bit of challenging there with people, but a lot of times I am more interested in like, okay, what is it about this experience that feels like a binge to you, right? There are things that I think can really feel like binges to people that like tells us more about like what their experience of their food intake and like their bodies and like whatever it might be, than just saying like, well, that's actually not technically a binge or like whatever. So it's like, yeah, it's an interesting dance of like supporting people and like fact checking or challenging, and then also understanding like there is something about this that feels like a binge, which to some people it might be like I eat super fast, and I'm like, okay, like let's understand what's underlying that, right? Or like I'm eating an amount of food that doesn't feel good at the end. And I'm like, okay, like let's understand what's going on there, right? So it's just interesting because it's like nothing is objective, you
Yeah,
know?
truly. Yeah.
Yeah.
Yeah. And I think that's such a good point. Like it's like what if this individual is experiencing any form of distress around eating, that's what we're exploring, right? It's like,
Mhm.
okay, whether this was appropriate or too much or
Mhm.
overeating or binging, it's like, that's not, yes, it's relevant. And what's the person's experience and how are they
Yeah,
feeling and why is this experience feeling so distressing? That's
totally.
so I
Totally.
think that's,
Yeah,
yeah.
because I mean, what I'll share is like I used to work in like higher levels of care, like in treatment, and there would be people who would come in kind of thinking like this is how much I'm supposed to be eating, right? Like this is the amount of food that my body needs. And then I would maybe give a meal plan that would be like significantly more than what they like thought that they needed. And so, like physical experiences after meals, if they're complying with that meal plan, could feel similar to what someone's experience after a binge would feel like, even though it's like that is a little bit to be expected, right? Like it's like when you're eating more than what feels right in a moment, there's a million reasons that could like lead to that, right? And so, it's not uncommon for people to be like, oh my God, like you want me binging throughout the whole day, where it's like there's something about this style of eating that feels that way that is not necessarily true to like the objective needs of a person's body, right? So like, yeah, it's subjective experience always really matters. And that's why we like to work with people to kind of like build at like the pace that feels okay to them.
Yeah, absolutely.
And like defining key terms is always super important.
Yes.
Yeah.
All right, let's get into, we've got a couple more. So I was going to talk a little bit about ARFID, so which is avoidant restrictive food intake disorder, which we do have a couple videos on already on our YouTube channel. So I will touch on it. And then if you're wanting more information or you're like, this sounds like me, or this sounds like somebody in my life, I think those videos could be really helpful. Marcy and Harley, two of the dietitians at TLB, did those videos and they're amazing. So
Yeah.
I think those will be good resources. But so the criteria for ARFID is having a lack of interest in food, sensory avoidance of food, or fear of consequences of eating. Somebody might have very few foods that they will eat, or few like textures potentially that can play a big role in this. What we will oftentimes see in order to meet that diagnosis criteria is significant weight loss or failure to thrive in young kids, sometimes nutritional deficiencies, dependence on nutrition supplements potentially in order for an individual to get those nutrients that they aren't getting in their diet.
Mhm.
Potentially tube feed, depending on the severity of the case. And then just overall, this is interfering with the body functions and everyday life. Typically, ARFID is not necessarily related to body image concerns. And so, if somebody is eating very few foods or just eating very little as a whole, that's not necessarily coming from like a body image standpoint. Typically, it is more of like sensory or lack of trust with food,
Mhm.
things like that. And let me see. Oh, it's also some of this criteria is just funny. It's like nothing else can explain the behaviors.
Right.
And then lack of food access is not at play either, right? Like
Right.
obviously if somebody is lacking access to a variety of foods, then intake will be limited.
Yeah.
But with ARFID, it's more so kind of like very, very strong food preferences or very intense fears potentially around certain foods and like inability to try it without
Mhm.
feeling kind of dysregulated.
Yeah. 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 I mean, I feel like you explained that really well.
Good. I
The
had to make up for bulimia. I
no,
lost I
no.
lost myself there. So
We were just warming up.
yeah.
But yeah, just that. Yeah, I think ARFID, I mean, I'm glad we have more videos on it because I can imagine questions coming up about it related to like, okay, well, like what distinguishes maybe like ARFID from like quote unquote like picky eating, right? Like all of that kind of thing. But what feels important to just kind of know, like reiterate from what you said is like that there is like a disturbance in like nutritional content or like there's a disturbance in like overall like nourishment in a person's body that is probably being caused less by like potential like body image or like that kind of thing and potentially more caused or root causes might be a little bit more related to like you were saying, right? Like fear of choking can be one, right? Or like swallowing difficulties for, like people who maybe like need to strengthen up like the esophageal like areas, right? Like that kind of thing. So yeah, just wanted to kind of like reiterate and clarify on those points.
Yeah, absolutely.
Mhm.
Yeah. And so again, like we have so many resources on ARFID and our approach with ARFID. And so if anyone is curious about, okay, well, if I have this intense fear of this food, how am I going to meet my nutrition needs?
Mhm.
We have a lot of information about our approach. And again,
Yeah.
like just getting support can be so helpful.
Yeah, totally. Yeah.
Awesome. All right.
Cool.
Our
I
last
think the
one.
last one is OSFED.
Mhm.
So, OSFED stands for Other Specified Feeding or Eating Disorder. And it can a lot of times be considered like the catch-all
Yeah.
category, right? So, like we were saying, for a lot of people, it's like, okay, this is an eating disorder, right? And for some reason or another, maybe like this person isn't meeting diagnostic criteria for like the other ones that we named. And so OSFED is intended to like still provide like some amount of like guidance for people of like, okay, you do have an eating disorder. And it's just hard to like define, right? That doesn't mean that it's any less serious or that we would take it any, that we wouldn't do our due diligence still with like the lab checks, right? Like all of that kind of thing. But yeah, having like the category of OSFED can be just really helpful when the other criteria is just like so specific sometimes that like having this is really helpful. So, for example, something that like can land in like the OSFED category, like I was talking about earlier, is like what we would call what not we, but like what is often called like atypical anorexia. So, because for quote unquote typical anorexia, a lot of times there is that like weight component to the diagnostic criteria. OSFED can be for someone who maybe like doesn't meet that criteria, but like still certainly is engaging in like eating disorder behaviors. Or, like individuals who are engaging in some form of like purging disorder, but they're not engaging in like binges, right? Like that kind of thing. So, I love OSFED because it helps us get like support and coverage for people who maybe like don't fit this like really, really like distinct like nitty gritty. But once again, just want to reiterate, it is like as medically and psychologically serious as the rest of the eating disorders, right? Like we take it very seriously. So I think that's what I've got to say about OSFED.
Yeah,
Yeah.
I think you covered it. Yeah, and I think anytime we're looking at like diagnostic criteria for anything, there are limitations, right? There are going to be individuals where it's like, oh, well, I meet one of these criteria, but not the rest, right? And it's
Mhm.
like, again, we we acknowledge these diagnoses, we use them for insurance coverage a lot of the time, and we're also working with the human that is sitting in front of us, expressing whatever they're expressing, having behaviors however they're presenting,
Mhm.
and whether or not there is this diagnosis, it is just as valid, just as serious, and yeah, again, like we're doing our due diligence no matter what.
Yeah, totally. Um, Yeah, so I mean, I feel like there you're talking a little bit about like why like diagnosis doesn't necessarily like define the severity, but yeah, I think it just helps to kind of reiterate that like this diagnostic criteria is helpful in a lot of ways and is way too specific for us to like only view through the lens of like the DSM, like diagnostic criteria, which is maybe like the point we've been making every single diagnosis that we've been talking about. So maybe I don't need to like really drive it home, but it
Yeah.
just feels important to say because it's so relevant to the experience, especially with like eating disorders, um, how misunderstood they are, like culturally, how like stigmatized they can be, this concept of like looking sick enough, right? Like all of that kind of thing. It just feels important to not add to that stigma by saying like, well, like if you meet the diagnostic criteria, great. If you don't, then like, sorry, you don't have an eating disorder or something like that.
Yes, absolutely. I think that can show up a lot, right? That like, am I sick enough to receive care? Like, am I taking this
Totally.
spot from somebody else? And it's like, no, absolutely not. You absolutely deserve care, no
Yeah.
matter what the like or yeah, whatever the diagnosis is or level of severity based on some of these markers.
Yeah, totally. So, yeah, anything else we want to share on like eating disorders or anything like that before we move on to like recovery support, etc.?
No, I don't think so. I think
Yeah,
that covered it. So,
yeah, sweet.
yeah, let's talk a little bit about recovery and then just like how we can support clients at TLB and what that
Yeah.
looks like. So yeah, again, like we already touched on just some of the like common myths about like what it looks like to receive support for eating disorder recovery.
Mhm.
So I don't think we necessarily need to emphasize that too much more, but I think just keeping in mind that like there can be medical risks across all of
Mhm.
these diagnoses, across all like levels of severity of these diagnoses. And it's
Mm.
important to get support at any level that you can. In terms of like what is eating disorder recovery, there are different levels of recovery. That's kind of how we refer to them as, right? There's residential, where you're going to a treatment center and you're staying there. And then we have PHP, IOP, and outpatient, which I feel like
Mhm.
could be a whole video in and of itself, just
Totally.
explaining what are the different levels of care, what does it look like to receive support at those different levels. But just know there are different levels. And so depending on severity and like how the behaviors are showing up, there may be different a different place to start and like kind of move through recovery. Some people start in outpatient and stay outpatient. Some people start
Mhm.
in IOP and some people start in residential. And so there isn't like there's no like correct starting point or anything like that. You can do an assessment with treatment centers to kind of figure out, hey, what would be appropriate based on how these things are presenting.
Yeah, totally. Yeah. Yeah, I feel like that's all really spot on. I do really think that we could do a video kind of giving a rundown of like what are the different levels of care and also like what does a collaborative like team approach look like, right? So like we were saying, we need if we're gonna get a diagnosis, like we need to get it from a different provider, whether that be a therapist, a psychiatrist, or a medical doctor. Um, and we also, like a lot of times, need labs. And so, guess what? Dietitians can't order labs. So we need a medical provider to order labs, right? And like the importance of having a therapist on board for the fact that like eating disorders are the way I describe them a lot. Maybe this is like the way a lot of people describe them, but it's like mental health conditions with physical health consequences. So we need to be treating the mental health, monitoring and treating the physical health, right? Like there's so much interdisciplinary support that has to like go into this is what I'll share with people.
Yeah, absolutely. Yeah. And if you're working with a dietitian at TLB, like we can help you build out that team.
Yeah.
We're more than happy to do that. So, but yeah, I think another video is definitely warranted on just like, I have clients ask me all the time, well, like, what is IOP? What is PHP? Like, what is that going to look like? How is that different than
Oh,
outpatient?
totally.
So,
Yeah.
yes, to be continued, I would say.
Yeah. Well, thanks so much for your time today, Sarah, and everyone who's watching this video. And yeah, stay tuned for more TLB snack chats. Let us know if you have any questions.
Absolutely. All right. Thanks. Bye.
Bye.